Welcome to the Deep Dive. Our mission is always to make complex research, sometimes really dense studies, and pull out the knowledge you need, giving you that critical edge. Today, we're tackling a really tough intersection. Substance use and recovery after a traumatic brain injury, TBI. It's often overlooked. We're digging into an observational cohort study, Beaulieu-Bonneau and colleagues from 2018. They followed 225 adults who'd been hospitalized for TBI, looked at their alcohol and drug use before the injury, and then tracked them for that critical first year after. And crucially, compared mild injuries versus the moderate to severe ones. And here's the kicker, the finding that really makes you rethink things. You'd imagine a serious head injury, well, it forces sobriety, right? But the data actually suggests something else. Yes, substance use drops sharply right after the TBI, mostly because, they're in the hospital. But then it starts climbing back fast towards those pre-injury levels by the end of that first year. It's a kind of post-hospital rebound, and it's pretty concerning.
That rebound is absolutely the core issue here. It really highlights that the initial sobriety might be, well, more enforced than chosen, and that window of lower use, it closes much quicker than you might think. But to really get why that rebound happens, we have to look at where people were starting from. You see, substance misuse isn't just something that happens after TBI. It's often a major risk factor for getting the TBI in the first place. The numbers here are frankly quite staggering. They really set the scene. At the very moment of the accident causing the TBI, somewhere between 36% and, get this, 73% of people were intoxicated.
Wow, 73%. So potentially 2 out of 3 people getting their brain injury while already impaired. That's huge.
It is a huge number. And focusing just on alcohol, between 23% and 53% had blood alcohol levels over the legal limit. And if you look at recreational drugs, maybe up to a third were under the influence right then at the time of injury.
Okay, so that immediately tells you, for a lot of these individuals, the TDI isn't some isolated event. It's happening within an existing, maybe chronic pattern of substance use.
Exactly right. And if you zoom out from just the moment of the accident, look at their history before the injury. It backs this up. Pre-TBI, somewhere between 31% and almost 80%, 79% of these patients had a history of alcohol misuse. That's heavy drinking or diagnosed abuse. And for drug use, it was between 21% and 44% with a prior history. So yeah, we're definitely starting the recovery journey with a population that's already at high risk, already grappling with substance issues. Makes the whole thing much more complicated down the line.
Okay, right. So let's unpack that recovery path then. The initial dip you mentioned, and then this seemingly inevitable rebound it starts makes sense with the dip. The study showed use dropped significantly right at the start. Alcohol, high-risk drinking, drug use, all down at that 4-month check-in compared to before the TBI, which, as you said, is probably during that intense medical phase, initial rehab, maybe access is just gone or heavily restricted.
But that's where it gets interesting. That drop is, well, temporary. When they compared those 4-month use levels to 8 months and then 12 months out, they found those early 4-month levels were significantly lower than what people reported later on. Alcohol use, risky alcohol use, even just the number of drinks per week, it was all climbing back up by months 8 and 12. That's the rebound. Clear as day. It happens relatively quickly.
And this isn't just contained at the first year, is it? The source material suggests this trend continues. They mentioned another study.
A prospective one.
Yeah, showing abstinence rates were around 30% after year 1, but that fell again, down to just 21% after year 2. So the momentum back towards using is pretty powerful.
Which brings up the obvious question, right? If we know this rebound happens, who is it happening to most? Who's driving those numbers back up? And that leads us to probably the most significant clinical finding in this study. The really stark difference between people with mild TBI, MTBI, and those with moderate or severe injuries. And it's kind of counterintuitive. The folks with milder injuries, they went back to drinking sooner and more often. The frequency of drinking after the TBI was significantly higher in the mild TBI group at all 3 check-ins, 4, 8, and 12 months.
That is quite shocking, actually. I mean, my gut feeling would have been the opposite. More severe injury, maybe more psychological fallout, more reason to, fall back on old coping mechanisms. Give us that data point again, the 4-month one.
Sure. So at 4 months post-TBI, almost 68%, 67.6% of the mild TBI group said they were using alcohol. Now compare that to the moderate severe group. At 4 months, only about 25%, 24.9% were using.
Almost 3 times the rate in just those first few months.
Okay. Yeah, it really shows how different those initial recovery paths are. The more severe injury essentially forces a longer period of abstinence, probably due to longer hospitalization and rehab. Now, by 12 months, that gap narrows quite a bit. The moderate severe group catches up, hitting about 61% use. but those early months seem critical.
It's interesting, though, this study mentioned that for drug use, the pattern was a bit different. Pre-injury drug use was higher in the moderate severe group, but post-injury use was similar between the groups.
That's right, which suggests alcohol is really the main driver of this early rebound difference based on severity.
So, okay, we need to talk about the why. Why does the mild TBI group bounce back to drinking so much faster? It can't just be that they leave the hospital sooner.
Well, that's definitely part of it. Accessibility, like you said, speed of recovery. But also, and this is crucial, maybe a lack of the right kind of support or follow-up. People with moderate or severe injuries, they often have long stays, intensive rehab, access is controlled, supervision is high. But individuals with mild TBI, they often resume their normal lives, their jobs, their social settings much, much quicker.
Right, back into the environment where the drinking happened before.
Exactly. And while they might look okay, they're often hit sooner and harder by the hidden stressors of TBI. Think about those persistent post-concussion symptoms, even after a mild injury. Problems with planning, organizing executive function stuff, increased frustration, mood swings, chronic headaches, sensitivity to light or noise.
Yeah, I can see that. If you're, say, 30 years old trying to keep up with work, family, social life, but you've got this constant headache and can't focus like you used to, you might look for something to take the edge off.
Precisely. The substance use can become a way to self-medicate, a kind of maladaptive coping strategy for symptoms others might not even see. And this points to a really critical gap in care. People with mild TBI often don't get that intensive, systematic rehab or regular medical follow-up that more severe cases do. Sometimes they get very little guidance, maybe just told to rest. They might miss out entirely on firm advice about abstinence, and maybe more importantly, they don't get help developing strategies to manage these new post-TBI stressors without reaching for a substance.
Okay, so knowing the rebound happens, knowing the mild TBI group is particularly vulnerable early on. Let's focus on the highest risk group identified in the study. That's the 11% who actually developed a full-blown substance use disorder, an SUD, within that first year. Can you define SUD for us quickly?
Sure. A substance use disorder, SUD, that's the clinical term, based on criteria like in the DSM system. It means a pattern of use that's chronic, causes significant problems in life, distress, basically addiction or abuse. And yeah, 11% of the people in this TBI study met criteria for an alcohol or drug SUD at least once in that first year.
How does that 11% compare to the general population?
It's much higher. The study cites general Canadian population rates around 3% for alcohol disorders and 2% for drug disorders. So having a TBI significantly bumps up that risk.
So who were these 11%? What characteristics did they share? The study found some key correlates, right?
It did. Three main things stood out when comparing those who developed an SUD versus those who didn't. First, age. They were significantly younger. Average age about 31 for the SUD group versus over 42 for the non-SUD group.
Okay, younger age. What else?
Second, relationship status. They were less likely to be in a stable relationship both before the TBI and after. Suggests maybe less social support.
Right, and the third?
Third, intoxication at the time of the injury itself. They were much more likely to have suspected substance intoxication noted in their records when they came in for the TBI. Over half, 54% of the SUD group, compared to only 20% of the non-SUD group.
Younger, less likely partnered, more likely intoxicated at the time of injury. Those are clear flags.
They are. But the single biggest predictor, the factor that overshadowed everything else really, was premorbid use, meaning their substance use patterns before the injury ever happened.
So it comes back to that baseline again.
Absolutely. And the study provides just incredibly stark numbers on this. Get this, out of 27 participants who did not use alcohol before their TBI, 0. None of them developed an alcohol use disorder in the first year after.
0. Whoa.
0. And for drugs, out of 150 people who didn't use drugs before the TBI, only one person developed a drug use disorder after.
Okay, that's massive. That really drives home the point that we're mostly dealing with a pre-existing vulnerability here. The TBI isn't causing the disorder out of nowhere.
Exactly. It seems the TBI interrupts the pattern, maybe forces a pause, but then the stress of recovery likely interacts with that underlying vulnerability, leading some back into problematic use or even a full disorder.
So the TBI is like an interruption, not a reset button.
That's a good way to put it. The key takeaway for anyone listening, especially clinicians, is clear. If you have a patient with a TBI, and they also have a history of substance use, that history is the biggest red flag there is. They are in the highest risk category for developing an SUD during their recovery.
And given those stakes, What are the consequences if this rebound happens, if used resumes? It's not just about, slowing down recovery, is it? It can actually make things worse long term.
Oh, absolutely. It actively undermines recovery and can contribute to worse outcomes. The research links post-TBI substance use to a whole host of problems, things like more complications while still in the hospital, greater brain atrophy, actual shrinking of brain tissue over time, higher rates of depression and anxiety, worse results trying to get back to work, and more significant cognitive problems long term.
And there's that terrifying feedback loop too, right? Using substances increases the risk of another TBI.
Yes, that's well documented. Heavy use increases the risk of falls, accidents, leading potentially to a second TBI, which obviously makes everything exponentially worse. It's a cycle we desperately need to break.
So what's the big recommendation coming out of this research then? How do we break that cycle?
The main message is the urgent need for systematic screening for substance use problems. It needs to become standard practice for all TBI patients. Doesn't matter how severe the injury was, doesn't matter if they're in formal rehab or not, everyone needs to be screened. Especially perhaps those mild TBI folks who might otherwise slip through the cracks but are rebounding early.
Are there good tools for that? Things clinicians can use quickly, maybe in an outpatient visit.
Yes, absolutely. There are well-validated brief screening tools, things like the SYSTAM, the Short Michigan Alcoholism Screening Test, or the ALL-UIT, the Alcohol Use Disorders Identification Test, and the DES for drugs, the Drug Abuse Screening Test. These aren't just simple "do you drink" questions. They're designed to quickly gauge the pattern and severity of use, look for signs of dependence. They help flag that risk level efficiently.
And what about interventions? Once you identify someone at risk,
The literature often points towards things like brief motivational interviewing, helping people find their own reasons to change their use, and practical skills-based interventions, teaching coping strategies, problem-solving skills. The key seems to be catching people early, maybe in that 4-month window when use is lowest, and offering support then.
okay, so this deep dive really casts a spotlight on a major challenge in TBI recovery. That recovery period isn't a clean slate at all. For many, it's just a temporary pause in substance use. And that mild TBI group, paradoxically, seems especially vulnerable to a quick return to use, partly because they get back to their normal, often stressful lives faster, often without enough ongoing support. And we know very clearly that pre-injury use is the single biggest predictor of who struggles most afterwards. So we'll leave you, the listener, with this final thought to chew on. Clinicians often recommend total abstinence after TBI. That makes sense neurologically. You want to protect the recovering brain. But given that this study shows resumed use is so tightly linked to pre-existing patterns, and that it often serves as a coping mechanism for new post-TBI difficulties like pain or cognitive changes, what practical non-substance coping skills do we need to be systematically teaching? How do we build healthier replacements for self-medication, especially for those mild TBI patients who might be discharged quickly and left to manage complex new symptoms largely on their own, without that safety net of intensive rehab? Something to think about until our next deep dive.